Well, up to now, the youngest I've operated on is a 27 years old guy. This is mainly because he's got a condition called primary hypercholesteremia. That means he's got a gene defect in his cholesterol metabolism.
Okay.
So he has got a total cholesterol of 15, 16. So they tend to get coronary artery disease at a very young age. And most of them, they get multiple blocks. And this is one of those young ones that I've operated on.
Specialist Centre isn't your typical hospital. It's Malaysia's premier quaternary hospital where rare, complex and next-level care comes to life. This is Quaternary Care, where our team of trusted super consultants are here to take on your toughest health battles using advanced technology and research-backed treatments all under one roof. Now, back to Nadia Azmi for UMSC's QRATED podcast.
Hello everyone, welcome to QRATED, brought to you by Specialist Centre or UMSC. I'm Nadia Azmi. Now picture this, you are young, you're fit, you're healthy, you go to the gym maybe twice a week and you eat right, but suddenly, bam, you have heart issues. You have some heart problems. What's the problem? What's happening? You're young. It doesn't happen to young people. That's one scenario. Picture the second scenario. You're a lady, you're a woman, and you go to the ER because of chest pains, but then they tell you that it's just anxiety. Okay, this happens when it comes to heart disease, gender gaps, gender biasness. Have you ever heard of that? We'll talk about it later in this part one, where we're going to talk about heart disease that occur among young Malaysians, young individuals, and number two, the gender gaps that happen in heart care. So in the studio this time for QRATED is Professor Dr. Imran Zainal Abidin, who is a consultant cardiologist. Welcome to QRATED.
Thank you.
Hope you're feeling hip and groovy today. If people still use those terms.
Yeah.
Yes. And next to you, we have Professor Dr. Sivakumar Krishnasamy, who is a consultant cardiothoracic surgeon. Welcome to QRATED, to both of you. Okay, I want to start off by each and one of you explaining your area of expertise. You both work with the heart at the hospitals. Yes, you see patients with heart problems and stuff. But maybe a little bit about the differences in your expertise. Can I start with Prof. Imran?
Okay.
Yeah.
A lot of people confuse both of us, on what we do.
Besides the fact that you're wearing the same color.
Yeah. So we are together. We are called the heart team.
Right. I love
Team,
that.
okay?
Yeah.
It's a heart team, but he does the surgical bit.
Right.
I do the medical bit.
So does that mean you come in first when patients come to the hospital to seek
yes.
treatment and help?
Often, yes. Especially when they come in with a disease like heart attack.
Yep.
So they will come to us first.
Yep.
As compared to him, maybe you will see them first if you have trauma or cancer.
Or dissection.
Those things. Then they will go straight to the surgery.
Oh, okay. So what happens when they see you, Prof. Asiva?
Okay, cardiothoracic surgery is a specialty by referral. So a lot of my patients are based on referral-based system. So I get my referrals from cardiologists, from chest physician, from oncologists, from vascular surgeons. So we are a subspecialty field where we deal with very specified area in the body, mainly the thoracic cavity, where the heart, lungs, and all the other structures are situated there.
Okay.
So that is where we deal with, and we treat them through surgeries.
Right. And today we're going to narrow in on heart disease or heart problems that occur among the young people. First off, when we say young, I know we have our definition of belia youth in Malaysia. They say under 30 or 35. But when it comes to heart problems, what age would you consider to be young? Under what age? What's the threshold?
Okay, it used to be anybody is younger than me is young,
Used to be.
But then I can't use that anymore.
Yeah.
Because I'm not in that age group
Right.
anymore. So what is defined as young will be those who have the disease when they shouldn't have at that particular age.
Okay.
Example given.
Is there a
Example,
certain number?
For example, coronary artery disease,
Okay.
heart attack, etc.
Okay.
So most of the time, it will start around the age of 50.
When the risk is higher.
Yeah, so that's the age normally when they get.
Okay.
And for women, maybe around 60.
I see.
So when they are younger than that, say at the age of 45 or 40, and they have a heart disease, we consider that as young.
And I think today we see more and more younger patients who are getting these problems
right.
that usually you would see in patients over 50 or 60.
Correct.
So when we talk about heart disease, heart attacks, it's often associated with the older people. But in reality, today, we see a lot of younger Malaysians suffering from this condition. Is that true?
True.
Do you see that in the
Very
hospital?
Very true. So it's not surprising if you get a 30-year-old that comes in with chest pain and a full-blown heart attack.
And it's not just among those who are very active in their daily lives. Athletes, for example, if I could give one tragedy that occurred and it was recorded on camera. In Indonesia, China's badminton player Zhang Jiji on July 1st, 2024, he actually died at the badminton court due to cardiac arrest after collapsing during a tournament. He was in the middle of playing badminton. And we've seen many cases where young individuals playing football and such collapsing while they're still on the field. Why do you think this is the case?
Okay, so that is classified as sudden cardiac death.
Right.
So when we look at sudden cardiac death and the causes, we have to divide them according to the age. For example, those who are younger here by definition is less than 50, and above 50 too, the causes may differ.
Okay.
For example, the badminton player.
Yep.
So he died from what we assume it was a cardiac arrhythmia. It's called cardiac arrhythmia.
Yeah.
So he probably had some genetic defects in him, undiscovered. And when he exerted himself, that triggered the sudden cardiac arrest.
And when you say exerted, it means when you stress your body, when you're extra active?
Yes.
Okay.
So you see that among the kind of sports that requires a lot of running, movements, like football, for example. Yeah. So football also you can see a lot of patients suddenly dropping.
Yes.
And then they have to come and resuscitate. So so those kind of conditions actually sebenarnya it's not that common. It is said about 2 to 5% of all sudden cardiac death. But it is very widely publicized because the event itself of him collapsing.
Yeah, it unfolded before our eyes. Yes.
Jadi it often becomes the talk of town.
And in a good way, the good thing out of it is at least people are more aware that this is happening and it can happen to the most fittest athlete.
I'll give you another example.
Yeah.
Who's our pocket rocket?
Azizul Hasni Awang.
Yes. It was in the papers, so it's not nothing that we don't know. He was lucky because he had symptoms while training, and it turned out that he has a congenital condition that could have resulted in his sudden death.
Yeah. Wow.
But it was averted by having the surgery.
This congenital factor, is it pretty common? Do you see this in a lot of your patients?
Siva can answer that.
Prof. Siva?
Right. Not many. Usually the numbers is probably less than 0.1, 0.2%.
Right.
The one that is more common is a condition called bicuspid aortic valve. That's about 1 to 2%. The rest of them are not very common. So the commonest congenital abnormality is related to the aortic valve. All the others are less than 0.1%. But these congenital conditions, majority of them are detected at birth.
Yes.
And they undergo whatever treatment that's needed during their growing years. Many that goes amiss are those that actually have a subtle type of congenital anomaly which actually didn't show any major structural abnormality or symptoms when they were born.
Yeah.
So they tend to grow through adolescence and into early adulthood with that problem. When does it get detected is when they start to push their body reserves and strain their heart And that's when symptoms starts to show. In some situation, it happens and they collapse and they just don't make it.
Yeah.
But in some situations, they come in with symptoms and then it gets investigated correctly and then they get the correct treatment.
Now, talking about symptoms, what are the early signs that often go unnoticed, especially in people who think they're healthy and fit? You know, it happens to people who go to the gym regularly, who, eat healthy. So is it because of lifestyle or environmental factors? Is it because of what they eat that contribute to the silent dangers, we call it, among the younger population?
Okay. Yeah, the scary thing is you don't have any warning signs.
There are no warning signs.
Warning signs. However, there are ways to detect
Yeah.
or risk, what we call risk stratification. One must know one's family history
Yep. Okay.
because often these diseases are genetically driven. There are genes that is passed down to one to another. So, and what we look out for would be symptoms of frequent faintings or someone like in a family who has sudden death episode or died at a young age.
And
died
it's like
during
unexplained.
sleep.
Yeah.
Like the actor, what's his name?
Ashraf Sinclair?
Yes.
He was he just came back from overseas and he was undergoing very intense training.
So knowing a little bit about family history would trigger us to do investigations.
Okay.
It is also healthy for anyone who does training or if you're active physically to do simple things like go and see a doctor, check your heart, listen to the heart, and then get an ECG. Because sometimes these tests, they can tell you signs that you may be at risk of something.
Yeah. What about lifestyle choices? You know, what you eat, whether you smoke or not. Does that influence the risk, whether it's higher or lower for one to get some kind of heart disease?
Well, if you have got pre-existing risk already, like what Prof. Imran mentioned, a strong family history or pre-existing congenital issues, adding on smoking, unhealthy lifestyle with food and sedentary lifestyle will further accelerate the disease. And what may happen in 10 years' time may happen now, right? So why this happens is because, again, the physiology in the body is such that we are designed in a way that we can take in some bad stuff and we can break it down and excrete it out.
Okay.
But too much of bad stuff, the body can't handle.
Yes.
And that's how it gets deposited in every other places in the body.
So it aggravates the situation.
It aggravates the situation. I mean, we all need some amount of fat, some amount of meat, some amount of sugar in the body.
Yeah.
But when it's more than usual, the body has got no capacity to get it out. So it gets deposited in various places in the body. And among the commonest sites are the blood vessels because that's where it travels.
Yep.
And a little bit of crack in the arteries and the plaque starts to form and it just carries on depositing and then it blocks the system and then you get accelerated plaque rupture and you get a heart attack.
Right.
So that's one scenario. Another scenario is again with sedentary lifestyle, you become obese, you put on weight, of course not active. That itself will bring down your mobility and then by not being able to move around a lot itself will cause, again, the heart health to deteriorate.
Yes. So I've done a few episodes on QRATED. Of course, every episode has a different medical issue. And I think the common theme or the common factor is always lifestyle choices, how they live their life, whether they exercise or not. That's always a big factor that contributes to all these medical issues. Now, Prof. Imran, although you said there are no early signs or symptoms, I was talking to a friend recently. She's probably in her early 40s. She's a mother of 3 kids. And one night she experienced a tightness in the chest. And she kind of mistaken it for gastric. But when she went to have a checkup at the hospital, it turned out that it was a mild heart attack.
Okay.
And she doesn't know where it came from. You know, her lifestyle, she's busy. She's always tired, yes, with 3 kids and all that. But you wouldn't expect that to happen to someone like her.
Okay, so that's where we come to about these gender differences. A
Okay.
guy that comes in with chest pain, we treat it differently. A woman that comes in with chest pain, especially a young woman, we brush it aside as anxiety.
Before this episode, Prof,
Hysterical.
I would never have thought that that was an existing issue, that is a thing when it comes to heart care. Yeah, okay, but Prof Imran, not yet. We will touch on that later. We just want to focus on the young Malaysians first. Prof Imran, keep that thought. Prof Siva, now you perform heart surgery. So in emergency heart surgeries like bypass procedures, how often do you encounter patients whose conditions actually could have been prevented, but they came in just a tad too late?
Actually, all the patients that we see can prevent themselves from getting coronary artery disease if they knew what they were doing or how they led their life in the earlier years.
Okay.
For example, if they were someone who took good care of themselves, especially patients who have got diabetes, good tight
Yes.
control of their sugars and regular checkups, they could have delayed their time for their disease to progress and cause all problems related to coronary artery disease. Same goes for smokers. They accelerate their disease even faster. I always tell my patients who smoke, you are paying money to buy your disease. So they do that. And then when they come over and they say, oh, I can't breathe, I'm having chest pain. I said, you paid money to buy all this. So that's...
In a way you did,
Yeah,
right?
in a way you did. So these are things that actually can be prevented.
Yeah.
Of course, how much they are aware of it, I don't know. It also depends on their level of education
Yes.
and understanding their peer group, their environment, many factors to decide on that. But whichever way, the guys that are coming to get treated under me or girls that come to get treated under me are at the end spectrum of the disease. That means nothing much can be done. Here, everything is blocked. You either get a stent, which Prof Imran does,
Yeah.
or you go for a bypass. When there's too many blocks, you come to me.
The thing is, Prof Siva and Prof Imran, when it comes to the younger people, we think we have a long road ahead of us. We have a long life ahead of us. So apart from education and awareness, we feel that there is no need to go to do that medical checkup. There is no need to do early testing because I am fine. I'm living my life. Do you see that kind of attitude among your patients?
Yeah, I mean, I
Or
do.
young.
Yeah, I do see that a lot in the younger generation. But the thing about the younger generation is they fail to realize that our body is just like a machine. The more you use, the more you trash your body, the body will give up one day.
Yeah.
So a lot of the younger generation people have got erratic sleeping patterns. They don't have enough rest, or they tend to stress, work,
So lifestyle issues, yeah.
peer pressure, and everything. All these are actually hidden risk factors that actually can contribute towards accelerated arteriosclerosis disease or even coronary artery disease. So if they feel they are in such an environment or working culture, they should go and get themselves checked, especially if they are getting tired more than usual.
Yeah.
I mean, usually the first thing that comes about is, I could do this a year ago, but I just can't push myself anymore. I'm just getting tired. I want to come back and sleep. I don't want to do anything else. Now, those are all telltale signs that your pump is not probably pumping enough. The
Right.
pump here I'm referring to is the heart.
And when we hear bypass, usually it's maybe a grandparent or an uncle who's much older. What's the youngest patient that you had to do a bypass procedure on?
Well, up to now, the youngest I've operated on is a 27 years old guy. This is mainly because he's got a condition called primary hypercholesteremia. That means he's got a gene defect in his cholesterol metabolism.
Okay.
So he has got a total cholesterol of 15, 16. So they tend to get coronary artery disease at a very young age. And most of them, they get multiple blocks. And this is one of those young ones that I've operated on.
So when heart disease is caused by genetic factors, it's hard or impossible to avoid, to prevent.
Exactly.
So they have to come and see you at the hospital. Now, Prof Siva, what are some of the most challenging heart cases that you have had to encounter among your younger patients? And probably this will also influence how you make assessments today.
All right. If you talk pertaining to coronary artery disease, the younger patients usually present with a more accelerated form of the disease, where the disease is more diffuse. They have got multiple blocks. So it becomes a challenge for me to find a good spot for me to put in the bypass graft. So sometimes I work together with my cardiology colleague, with Prof. Imran and team, where they may open up a certain area of the vessel to allow me to have a good place to land my bypass graft. So those are certain real world challenges I face. And some, they even come with combined pathology, not only coronary artery disease, they come with a valve that is already damaged, and that can be due also to either congenital problem or rheumatic heart disease, or even sometimes degenerative causes due to that. And some of these patients with combined problems with coronary artery disease and valve problem, they actually pose a higher risk of operative risk. That means chances of having a perioperative related death or complications. So these are some of the complex cases that we do deal with when they come with multiple pathologies.
So some patients, are they not fit to go into surgery?
Oh yes,
Does that happen? Yeah.
yes, we do. We do. I mean, we in University Malaya, we have got a very strong heart team where we tend to discuss most of the complex cases together, and we tend to put these cases up to get opinion from all other fellow colleagues, not only surgical related opinion, but also cardiology or alternative treatment pathway for these patients. At the end of it, our true aim and hope is to give the best form of safe treatment for the patient. Of course, the ideal treatment may not be the best treatment for that particular patient.
Yeah.
So finding other options and other safer alternative is what we discuss. And our aim is exactly the same between both groups of practitioners. We want the patient to go back home with a reasonable quality of life and to be alive.
Yes, of course, definitely. Now, I want the both of you to illustrate to us in a situation when something goes wrong, a patient comes in with chest pain or suspected heart attack. Okay, so what does the treatment journey look like for that patient? And how do the both of you actually come together? How do your roles intertwine?
Okay, maybe
I think,
Okay.
Prof. Imran will do that.
So they come to the emergency department first.
right.
That's where I will plead to those who are watching this podcast. If you have chest pain and not sure what it is, please just go to the emergency department. When you present yourself at the emergency department, just tell the triage counter officer, so I've got chest pain. They will immediately do an ECG.
Okay.
So why does this matter? Because the timing, this is what I call time is myocardium. Because the onset of the pain and the treatment that we give will determine your survival.
Wow. Okay. Another issue to that, though, I want to ask Prof. Imran, how do you differentiate between, just normal chest pains, rasa menyucuk-nyucuk,
Right.
between, something that's totally normal, or maybe it's nothing to be concerned about, to something that is quite severe and it really has something to do with the heart? How do we tell the difference?
This goes back to the gender lah. Because men presents typically. Women, it's always complicated.
Right. Okay, we're going to delve more into that. But
Okay.
let's continue with, when they come into the ER, what happens next?
Okay, so when you come into ER, when you complain of chest pain, they will do an ECG, regardless of what sort of chest pain that you have,
Okay.
because a true heart attack will appear on the ECG. Okay, let's say, what's the best timing? As soon as possible. Meaning that you don't wait. When you have chest pain, you will go to the emergency department and we get it sorted out. Okay? If you come early, there's not a lot, because when you have a heart attack, the whole vessel is blocked with actually blood clots and so on.
Okay.
So you get admitted to the emergency department. The best treatment would be to perform an angioplasty.
All right.
Angioplasty means we'll put catheters into your arteries and then we put in a balloon to the place where it is blocked and immediately open it up. And we're supposed to do this from the moment you step into the emergency department to the ballooning in 60 minutes.
Would this be something you do? Is this under your purview?
Yes.
Okay. Okay.
So that would be the best. And if we manage to do that, we will minimize damage to the muscle. Then you you can lead a fairly good life after that.
Okay.
The problems we have is that there's a delay.
It's always like that.
Yeah.
We are unsure, we're sure, we don't know what's happening, or we are afraid to come into the emergency room. We're just afraid of hospitals in general. So maybe that
So
sometimes
when there's a
delays it.
delay, a lot of muscles are damaged.
Yeah.
And then there's nothing much that we can do at that moment to save the muscles. But we still can do something for the rest of the vessel. Now, when does he come in?
Yes, Prof.
Okay.
Siva.
So that comes after my initial
Right.
angiogram.
Okay.
And if it involves certain type of blockages, then we will refer to him. So, Siva, you can tell.
So the first line of treatment will always be done by the cardiologist.
Okay.
So that's Prof. Imran and team. And what they do is actually life-saving. Because when the patient comes in, what they call as the door-to-needle time, if it is done correctly and accurately, the life would be saved. And there's enough studies that have proven that worldwide. So that is actually gold standard treatment for acute myocardial infarction, or what we say as heart attack. Now, when do I come in? After they have done the angiogram and they find that there are more than 2 or 3 blocks, or the blocks are very complex, where they have got no areas to land their stent or to open the vessel up because it's very calcified or diffuse, then that becomes a bit of a limitation to the technology they have to open the vessels up. So how do we deal with that? Then we deal it externally. So when we talk about myocardial protection, it's all about blood flow to the heart muscle.
Yeah.
So the blood flow to the heart muscle can be done through internally, and that's where you put in stents and balloon, or externally, and that's where we call bypass.
Yep.
So bypass meaning that you have got a block, but we create a new channel or a new pathway to divert the blood from the blocked area into the blood vessel below, which are fairly decent size channel to perfuse the muscle.
Okay.
So in other words, you have got a drain that is blocked. The water is getting stuck and can't flow downwards. You can't break that whole concrete pile or cement that is blocking everything. So you just divert the flow and create a new pathway below that. And that's how bypass is in
Like
simple
a
terms.
Plumbing system in our heart.
I'm just a glorified plumber. So that's what I do.
Yes. And you save lives.
Yeah,
so
plumbing in the
that's
heart.
important. Our heroes.
Yeah.
He does the renovation.
Renovation.
Jolok je.
You're contractors at the same time.
Yes.
Now, let's go into the gender gaps. I know that Prof. Imran is eager to talk about this. The gender gaps when it comes to heart disease. I'm sure a lot of our viewers are wondering, why are we talking about gender gaps when it comes to heart disease or heart care? So, touching a little bit on genders, there's a well-documented study that highlights the significant gender bias in diagnosis, treatment, and outcomes of cardiovascular diseases between men and women. Despite it being a leading cause of death actually for both genders, for both sexes, women often face disparities. Okay, and that, of course, will in turn affect the care and survival rate as well. And global statistics state that women are about 50% more likely to be misdiagnosed with a heart attack compared to men, even though their risk of developing cardiovascular diseases is similar. This is a big thing for us to ponder upon and to think about, because this is happening globally, right? Not just in Malaysia, but globally. And one of these long-term biases happen due to the predominance of male leadership and workforce in cardiology. I'm just stating what the studies have shown, with many saying that this has led to less attention being given to women. Okay, this is very unfortunate. Less attention to female-specific cardiovascular issues. So basically, in other words, women are overlooked. That's why I had my example in the introduction. Let's say a woman comes in the ER with chest pain. Then they're gonna be told that, oh, don't worry, it's just probably anxiety or a mental breakdown. And then also some have said that even the machines, the equipment being used in heart care for heart disease, they are designed based on a man's anatomy, a man's body type. ignoring, the structure of a woman's body. So clearly, this is a big problem that we need to address. What are your thoughts, Prof?
Okay. If you say because there are more male doctors, that's why there's a gender bias, that's not true.
Okay.
That's definitely not true. I think women doctors are worse when you have a women patient. No?
Why?
You think
That's a
of
very
so many
contentious
things
statement.
and connectivity. Then let's talk about facts.
Yes.
Why? I can give you 3 reasons why this happened.
Okay.
Firstly, it is the statistics, historical statistics.
Yep.
It is well known that women have very low cardiac risk during menstruation period.
Okay.
And they start to have cardiac complications about 10 years after menopause. That is proven fact.
Okay.
Okay.
Never
so
knew that.
statistically, it's like that.
Okay.
So, and it's being taught in medical schools. And we all know that if you are still menstruating, it's very unlikely for you to have a coronary artery disease. Okay.
Interesting.
And this is because the effects of the estrogen
All right.
protection.
All right.
Right. So that's reason number 1.
Okay, before you go on to the second reason, but now the reality is the patients are getting younger and younger. Does that affect that piece of statistic? Does that change the
Okay.
statistic?
That's why I have to finish the other
Okay.
2. Okay.
Proceed.
Okay. So that sets the stage
Right.
for current doctors
Uh-huh.
when they look at patients that come in with chest pain. Number 2 is that the presentation of chest pain among men and women, they are different.
Okay.
Okay. Men will present with symptoms that is typical textbook. Okay.
Okay.
And it will be like heaviness of the chest, big area, like a stone. Sometimes a crushing kind of pain, sweating, etc., etc. So it fits the textbook. And when they come in to the emergency department, it is often diagnosed accurately.
Okay.
Okay? Often. Women, for reason unknown, they do not have similar symptoms to men.
Okay.
They often present with breathlessness.
Breathlessness, that's one for women.
Breathlessness, women.
And that's when they are maybe climbing up the stairs or just at any time of the day, even in a static position.
It can be in those positions. It can be upon exertion, it can be at rest. So when they present with atypical symptoms, takes a longer time for us to realize that it's really hard. Okay.
That makes sense.
Thirdly, is the women's selflessness attitude, especially mothers.
Okay.
They tend to put aside their symptoms and they will take care of the rest of children, the husband. If they have a bit of pain or breathlessness, they just put it aside and just go on.
So all mothers out there, please pay attention to this. I mean, that is typical of a mother who's caring for a family, that their health is not priority.
So it's true, it is proven in studies that women comes later than men to the emergency department.
Coming back to the example that I gave of my friend who's in her early 40s, so she's busy caring for her 3 children. She felt that tightness in her chest, that feeling. I think it was for a few days before she actually went to see a doctor to see what the problem was. Because you're too busy with life.
Yes.
Life gets in the way. You don't think about your body
Yes.
and how it's breaking down.
Yes.
So tightness in the chest, isn't that a typical or a common symptom also experienced by men?
Okay, so let me tell you how it feels. Most people will say, I got pain here exactly at that point. That's not cardiac.
If you can pinpoint the exact
You can pinpoint,
spot.
it's just right here, doctor.
So it's not.
Right here. No, it's not. That's not cardiac. It is diffuse. The
Right.
entire chest wall, okay, it feels like a stone on your chest. Okay, and when he exits, it becomes worse. If you have a pain and it is only at rest, when you walk or you run, it disappears, it's unlikely to be a coronary block.
Okay.
Because it gets worse. Okay, so those are the most common symptoms.
Right.
In women, sometimes not clear. Now, coming back to women, why is it now the statistics has shifted? Why is it now women having heart disease? It used to be when we were younger doctors, Prof. Siva, 40s, we'll be shocked. Oh my God, he's got a heart attack. I didn't realize that.
Maybe because these days men give women more problems.
You
Joke
might
aside.
Uh,
Joke aside, why? Prof?
Okay, all right. So I give you a few reasons.
Yeah.
Number one is that there is a rise in hypercholesterolemia, especially in Malaysia.
And what is that, Prof. Imran?
We believe it's genetic.
Okay. So is that because of environmental issues again? If we didn't see it back in the day, why are we seeing it suddenly if it's a
Yeah,
genetic
there is
issue?
a component of lifestyle.
Mm.
We eat differently nowadays.
Yes, yeah.
So that contributes to the already background of genetic defects. So younger women will have higher cholesterol at longer period. That's number one.
Okay.
Number two, there's a rise in hypertension among women.
Okay.
Women are presenting with high blood pressure earlier in life. And some of them are driven by the most common psychological disorder nowadays that I face among my patients,
Yeah.
anxiety disorder.
I see.
Yeah,
So mental wellness, mental health is actually interrelated
Yes,
with heart disease actually.
correct. When you have anxiety, you're running this, oh my God, the kind of thing, and the pressure at work, it drives the blood pressure up. And they present earlier with high blood pressure. So having these two is already strong enough risk factors, especially hypertension.
Yeah.
Because when you have hypertension, you have no symptoms. You just have high blood pressure. You don't know unless you put a PP cuff over you.
You don't realize what it's doing to your body
Right.
because you're always on the move. Maybe you're always working. You love what you're doing, but you're tiring out, you're wearing out your body in actual fact.
These two, no symptoms.
Prof. Siva, do you agree? Do you share the same sentiments when it comes to gender gaps in heart disease, heart care as well?
In my area of practice, like I mentioned earlier, I don't usually face this because the patient has already been diagnosed and referred to me. So I see a fair bit of almost I would say equal distribution between male and female because I deal with cardiac patients, thoracic patients, aortic cases. More males are still coming under my care for treatment for coronary artery bypass graft, but the number of female patients also increasing over the years. And as what Prof. Imran mentioned earlier, the main contributing factor here is probably hypercholesteremia, diabetes at a younger age, hypertension at a younger age. So these all tend to accelerate the disease and they tend to come at a much more younger age, even while they are in their, period of before they menopause.
Yes.
So, it's always a belief that while they are in their reproductive age group, they are somewhat protected by the estrogen effect. But that doesn't apply if you have got multiple pre-existing medical conditions like diabetes, high blood pressure, or even the number of women who are smoking nowadays are pretty high compared to what was it like in the past. So if you say that in the past, the numbers of women presenting with coronary artery disease were low, but that's not true anymore because women are beginning to lead the lifestyle of like a man nowadays. Sole breadwinner or single mother, stress, just like how a male would face in their work and life. So they're almost equaling up.
So while women present different symptoms and the factors may differ as well, from a surgical standpoint, does that change your approaches when it comes to cardiac operations?
No, they don't. But in our surgical risk stratification, we use a scoring system called the Euroscore. Being female gives you an additional 1 point. That means additional 1% risk of dying compared to a male. Now, the reason why is because female carries a slightly different anatomy than male. They have got smaller coronary artery disease, smaller conduits. Conduits means spare parts in the body, the blood vessels we use to bypass. And because when they present to us, they are the other end of the spectrum already. So that's why they pose an additional 1% higher risk than a male. So being a female itself already gives you a 1% risk of dying more than a male.
Wow. Okay, so my next question to wrap up part one, what are the changes that need to be done to fill in this gap?
I think awareness. Awareness. Take that first step to know what's your baseline.
So awareness among medical practitioners or among the population in general?
Population starts first.
Okay. Okay.
Population must be aware that, I need to get my cholesterol check. I need to do a blood test and see how I'm doing. But that's my baseline. Have a blood pressure check. And to remind ourselves to do this, maybe annually, just to see how we are doing. So that kind of awareness, you will be able to pick up things that we don't realize, especially when you have risk factors.
Yeah. Do that medical checkup annually, even though you think you're a little too young, things can still be detected at an early stage.
Yes.
Issues can be detected.
Yes.
Yeah. Okay.
Especially high blood pressure.
Right. Prof. Siva, what changes do you think we should be seeing?
I think in terms of changes, I totally echo what Prof. Imran said in terms of awareness. More than awareness is that I think people have to be responsible over their own health and their own body. Nobody can actually screen through your body and say you've got a heart condition or you have got a lung condition or you've got this cancer, this growth. It's only you who know yourself. And I think age is not a number that you should look at to get yourself checked. I think everyone should check themselves at least once a year with a simple routine blood checkup and maybe an x-ray if they think they have got symptoms related to lungs or something that bothers them in that line.
Yeah.
And I guess by doing this, you would be surprised the number of people that actually may find something is wrong with them. And that would enable them to seek specialist healthcare treatment and then get themselves sorted at a much younger age. By doing that, they then prevent themselves from coming to see me or Prof. Imran.
Right.
Seeing us is at the end stage of the spectrum. You don't want to see us.
Of course. So let's be more proactive in taking care of our bodies, in pinpointing issues that we may have, medical issues at an early stage, so that we can prevent it from becoming even more severe. And so our treatment can be controlled. It doesn't have to be so extreme. And at a young age, you want to stay healthy and fit for many, many more years. Okay. Thank you so much, Prof. Imran and Prof. Siva, for that first part of the discussion. It was very, very eye-opening. And the trend, yes, it is worrying because more and more young Malaysians or young individuals, even globally, are actually getting heart diseases and encountering heart problems. So yes, again, let's be more proactive and do something about it. We can start by having that annual medical checkup. Okay, so stay tuned because we still have part 2 where we will explore how UMSC's quaternary care makes a real difference from technology to teamwork. In the meantime, if you haven't done so, please do QRate us by subscribing, sharing, commenting, and yeah. Can I do that line one more time? Okay. And if you haven't done so, remember to QRate us by subscribing, sharing, and commenting. We'll see you in part 2.
Did you enjoy today's curated episode? Well, don't forget to tune in for the next episode of Curated Podcast by UMSC. To learn more about our consultants, specialties, or to book an appointment, visit umsc.my. For health tips, behind-the-scenes content, and expert insights, follow UMSC on Instagram, Facebook, TikTok, Spotify, and Apple Podcasts. Till next time!